Hello, I'm Dr. David Ilson. I'm a medical oncologist, and I practice at the Memorial Sloan Kettering Cancer Center in New York City in the United States. The topic of my lecture is gastric cancer advances in systemic therapy. These are my disclosures. These are really consulting agreements with various pharmaceutical companies. We know in stomach cancer that chemotherapy added to surgery improves survival. The most common approach in the West is to give chemotherapy before and after surgery using a regimen called FLOT, which combines 5-FU, oxaliplatin, and docetaxel. In Asia, particularly in Korea and Japan, surgery first for stomach cancer is followed by chemotherapy after D2 surgery. The most common regimen used after surgery in Korea is capecitabine and oxaliplatin for 6 months. This was established by a trial conducted in Korea called the Classic trial. A more recent Korean study indicated that 6 months of chemotherapy was still appropriate using S1 plus oxaliplatin, and it was actually superior to a year of S1 alone in patients who had lymph node positive stomach cancer. Approaches in Japan also include using S1 for a year, and a combination of S1 and docetaxel is better than S1 for a year in stage 3 disease. An older approach of surgery followed by radiation and chemotherapy in the United States is generally only done if the surgery is not adequate. For metastatic disease, in the United States, the NCCN panel endorses chemotherapy treatments for metastatic disease, and 2 chemotherapy drugs is the most common practice. We usually give patients FOLFOX, capecitabine, oxaliplatin, or FOLFIRI. In Asia, we would typically combine S1 with cisplatin or oxaliplatin. 3 drugs, adding the drug docetaxel, are not recommended for metastatic disease. There is no survival benefit for 3-drug chemotherapy over 2-drug FOLFOX in patients 65 and older, and a recent large Japanese trial showed that there was no survival benefit combining docetaxel with S1 and cisplatin over S1 and cisplatin alone. We also add the drug trastuzumab or Herceptin to chemotherapy in HER2-positive disease. And the exciting news now in the United States is that immunotherapy is approved for initial chemotherapy treatments in virtually all patients. For HER2-positive patients, we would add pembrolizumab to chemotherapy. For HER2-negative patients, we would add nivolumab to chemotherapy with FOLFOX. And in HER2-negative esophageal cancer, we would now add pembrolizumab to 5-FU cisplatin or FOLFOX chemotherapy. HER2-positive esophagogastric cancer is very different from breast cancer. Until recently, the only approved drug to give to HER2-positive patients was trastuzumab or Herceptin, and it is approved to combine with chemotherapy first-line in HER2-positive gastric cancer based on a global trial called the TOGA trial, which showed that survival was improved when trastuzumab or Herceptin was added to first-line chemotherapy. However, other drugs, including lapatinib or pertuzumab, did not improve outcome added to first-line chemotherapy. Recently, there was promising data for immunotherapy added to chemotherapy in HER2-positive patients. A trial from Sloan Kettering combined pembrolizumab with trastuzumab and chemotherapy, and it showed an impressive 83% response rate and a survival of more than 2 years. This led to a phase 3 trial, Keynote 811, which is adding trastuzumab or Herceptin to first-line chemotherapy in HER2-positive gastric cancer. And preliminary results showed a much higher response on this trial when pembrolizumab was added to chemotherapy. And based on the data from the trial Keynote 811, pembrolizumab is now approved to combine with Herceptin and chemotherapy in first-line HER2-positive gastric cancer. There are some newer drugs, and the most important that was recently approved in the US and Japan is trastuzumab deruxtecan, or Enhertu. This is trastuzumab conjugated or combined with a chemotherapy drug in one drug. This drug showed a 43% response rate even after resistance to previous treatment with trastuzumab. And in a recent phase 2 trial, trastuzumab deruxtecan was superior to chemotherapy and led to regulatory approval for this drug in the United States and Japan. Another promising drug that is still being studied is margetuximab. This also targets HER2. It is an anti-HER2 antibody optimized to increase activation of NK cells, which are immune cells. And in a phase 1/2 trial combining this with pembrolizumab, encouraging results were seen. There is an ongoing first-line trial of margetuximab combined with chemotherapy and immunotherapy drugs that is ongoing. Another drug that is moving forward is a drug called zanidatamab, which targets HER2 and HER3, and also looks promising when combined with chemotherapy. I just want to comment a little bit about trastuzumab deruxtecan. Again, this takes a Herceptin-like molecule and links it to a chemotherapy drug. And essentially, this drug delivers the chemotherapy drug to the HER2-positive cell. The randomized trial that led to approval of this drug was the phase 2 Destiny trial. And on this trial, patients had to progress on previous treatment with Herceptin, and then they were randomized to physician's choice chemotherapy, either irinotecan or paclitaxel, or trastuzumab deruxtecan. The response to trastuzumab deruxtecan was 3 to 4-fold higher, 43% compared to only 13% for chemotherapy alone. And you can see here in this graph that this translated into better survival. Patients lived longer if they got trastuzumab deruxtecan compared to chemotherapy. Also, patients were on treatment longer. Progression-free survival was better. Patients were on treatment longer if they got trastuzumab deruxtecan compared to conventional chemotherapy. And again, this drug is now approved in second or later line treatment in HER2-positive patients. What about angiogenesis drugs? The one that is approved in the United States and in Asia is ramucirumab. This targets a pathway called the VEGF receptor. The important use of this drug is in second-line chemotherapy. Ramucirumab plus Taxol was superior to Taxol alone. You can see that it improved survival in patients, and it also improved time on treatment and response. So this is now standard second-line chemotherapy in gastric cancer. The first-line trial of ramucirumab plus chemotherapy was not successful, and you can see here there was no difference in survival for first-line use of ramucirumab. The last drug I want to mention in the chemotherapy discussion is TAS-102. This is used in third or later line treatment, and based on the TAGS trial, this looked at TAS-102 versus supportive care alone in very heavily pretreated gastric cancer. And TAS-102 resulted in a modest improvement in survival compared to chemotherapy alone, and also an improvement in time on treatment, progression-free survival. So this drug is now approved for third or later line treatment in advanced gastric cancer. Another drug that's very promising in research studies is zolbetuximab. This targets a protein called Claudin 18.2, and you can see that gastric cancer very commonly expresses this protein. More than 70 to 80% of patients overexpress this target or protein. Zolbetuximab targets this protein. And there were promising data combining zolbetuximab with chemotherapy. In all patients treated on the trial, there was a 5-month improvement in survival, and patients that had high level of expression of Claudin 18.2 had a very striking survival benefit. So there are ongoing trials in Claudin 18.2 overexpressing patients combining FOLFOX with zolbetuximab or capecitabine oxaliplatin with zolbetuximab. I want to close my talk reviewing the results for immunotherapy. Immunotherapy in esophagogastric cancer has yielded positive results across the line, and immunotherapy drugs are now approved for use in the United States. Originally, these drugs were approved in chemotherapy-resistant gastric cancer. In the United States, the trial Keynote-59 led to approval of pembrolizumab in PD-L1 positive or MSI high gastric cancers who had failed all other chemotherapies. And similarly, in Japan, nivolumab was approved for chemotherapy-resistant cancer for gastric cancer patients that had received multiple prior treatments. Comparisons of immunotherapy with second-line chemotherapy drugs led to approval for both pembrolizumab and nivolumab in esophageal squamous cancers, but not in gastric adenocarcinomas. And now we have first-line approval for immunotherapy drugs combined with chemotherapy. The trial Checkmate 649 showed that nivolumab added to FOLFOX was better than chemotherapy alone in gastric cancer first line. The trial Keynote 590 showed that combining pembrolizumab with 5-FU-cisplatin in esophageal cancer was superior to chemotherapy alone. And Keynote 811 in HER2-positive patients showed that pembrolizumab added to Herceptin in chemotherapy was better than chemotherapy alone in gastric and esophageal cancer. So we now have approval for checkpoint inhibitors in the United States in chemotherapy-resistant disease, and now in first-line chemotherapy treatment in initially diagnosed patients. I just want to review the results briefly. These are the results for nivolumab plus chemotherapy over chemotherapy alone from the Checkmate 649 trial in first-line treatment of gastric cancer. You can see in the survival curve that there was a significant survival improvement for nivolumab added to chemotherapy over chemotherapy alone, and this benefit was sustained in the long term. This was in patients that had PD-L1 positive scores of 5% or higher. But even in lower expressors, CPS 1% or higher, or all patients treated, there still were survival benefits seen. The response rate was also higher. 45% for chemotherapy alone improved to 60% with the addition of nivolumab, and the duration of response was much longer for nivolumab plus chemotherapy versus chemotherapy alone. So nivolumab is now approved in the United States to combine with first-line FOLFOX chemotherapy in metastatic gastric cancer. Similar data were seen for nivolumab in an Asian trial, Attraction 4. This looked at S1 oxaliplatin or capecitabine oxaliplatin with or without nivolumab in gastric cancer. And in this trial treating over 700 patients, you can see that time on treatment, progression-free survival was higher, a 10% improvement in response rate, a 4-month improved duration of response. Survival was not improved on this trial because many patients crossed over to get immunotherapy later. But this trial provides supportive evidence for a benefit for nivolumab added to first-line chemotherapy. We now have results positive for pembrolizumab plus chemotherapy versus chemotherapy alone in the first-line treatment of esophageal cancer from Keynote 590. Here you can see in esophageal squamous cancers that were PD-L1 positive 10%, or all esophageal squamous cancers, significant survival benefits adding pembrolizumab to chemotherapy versus chemotherapy alone. And if we look at all patients that were PD-L1 positive 10% or higher, again, there was a significant survival benefit, but also in all patients, there was a modest survival benefit for pembrolizumab plus chemotherapy versus chemotherapy alone. And again, if we look at response, this was significantly improved from 29 to 45%, and the duration of response was much longer. So based on these data, pembrolizumab is now approved to combine with first-line chemotherapy in esophageal adenocarcinoma and squamous cancers. The last comment I want to make about immunotherapy, not only do these drugs help in the metastatic advanced disease setting, but we have recent positive results for giving nivolumab after surgery, after resection of esophageal or gastroesophageal junction cancers, when patients got chemotherapy and radiation followed by surgery. Patients were randomized to get a year of nivolumab or observation after chemotherapy, radiation, and surgery. And you can see that disease-free survival was significantly improved. It was actually doubled. For patients undergoing surgery alone, about half of patients recurred within a year. This was improved to 2 years. There was a significant improvement in disease-free survival for nivolumab versus placebo. Based on these data, we now have regulatory approval in the United States for nivolumab in esophageal cancer, squamous and adeno, after chemotherapy, radiation, and surgery. So to summarize, we can see that there are a lot of important new advances in the systemic treatment of gastric cancer. Chemotherapy, either added before or after surgery, improves survival compared to surgery alone, and the most common approach in Korea would be S1 or capecitabine plus oxaliplatin given for 6 months after surgery. In metastatic disease, 2 chemotherapy drugs are used, either 5-FU oxaliplatin, 5-FU irinotecan, or capecitabine or S1 combined with either cis or oxaliplatin. For second-line chemotherapy, we either use Taxol or irinotecan, and if we use Taxol, we combine it with ramucirumab. Third line, we use TAS-102. For targeted therapies, if patients are HER2 positive, we combine trastuzumab or Herceptin with first-line chemotherapy, and we now have approval for a second or later-line drug in HER2 positive patients, trastuzumab deruxtecan, which is approved for HER2 positive patients second or later line. Immunotherapy should now be combined with first-line chemotherapy in advanced gastric cancer. The combination of FOLFOX and nivolumab is the new first-line standard in gastric cancer treatment. Pembrolizumab can be combined with 5-FU cisplatin as the new first-line standard treatment in esophageal cancer. And in HER2-positive patients, we can combine pembrolizumab combined with Herceptin and chemotherapy as a new first-line standard. The older approvals are pembrolizumab and nivolumab approved for MSI-high and PD-L1 positive refractory esophagogastric cancer. And then again, in squamous esophageal cancer, pembrolizumab and nivolumab are approved second line. And now we have exciting data after chemotherapy, radiation, and surgery in esophageal cancer. Nivolumab is now approved to administer as a post-surgery treatment, which improves outcome. Thank you very much, and we'll try and have some questions.